No, I know. Okay, ladies and gentlemen, good afternoon. I think we'll make a start. Thank you for your patience. My name is Moazzam Malik. I'm Chief Executive with Save the Children UK. It's my pleasure to be moderating this event today on delivering improved health outcomes for all, exploring the drive for effectiveness and innovation in challenging times. I'm delighted to have an illustrious panel with me. I will introduce them when we turn to the panelists. And I'd also like to welcome people who are tuning into this session on the live stream. It's very nice to have a broader audience for this hugely important subject. I'm looking forward to a fruitful conversation. Just in terms of housekeeping, to say that we'll hear from the panelists one by one, and then we'll have some time for interaction with the audience. Unfortunately, people online I don't think can tune in, but those here in the room will invite you to show your hands and to speak at the mic and to direct questions or comments to the panelists or as you wish. We're very much at a crossroads in human development. Many of the SDG goals remain off track, and the WHO's latest statistics report a stark picture on the prospects of meeting the health-related SDGs by 2030. Of course, we also know that health needs around the world are immense, and that health is a major priority for governments, for development partners, but of course also for communities, and in our case, particularly mothers and children that we work with in more than 100 countries around the world. We also know that a whole range of institutions have ambitious plans in place, including the World Bank with the commitment to support 1.5 billion people. But at the same time, we're living in a time where public financing is falling rapidly, following the end of COVID-19, and most recently with the cuts to ODA by a whole range of major partners around the world. And those cuts in bilateral budgets are beginning to come through into the multilateral budgets too. The MDBs may be a notable exception in that regard, but nevertheless the pressures across the board are extreme, and I'm sure many of you will have seen the numbers that the OECD DAC reported in the last few days, with ODA falling to around 0.26 of OECD GNI, and I don't think we're at the bottom. I think over the next couple of years we're likely to fall to somewhere around 0.22, 0.23 or so. So there is still more pain ahead. And of course, this pain isn't just reflected in the ODA numbers or in numbers of people employed in development institutions, but it's reflected most directly in the lives of people on the ground. And in the last few months, I've been in Ethiopia, I've been in Somalia, I was just in Sudan a few weeks ago, and witnessed the devastating impact of cuts to development budgets playing out with the closure of health clinics, pressures on schooling, and it's fair to say that there are people losing lives. You know, when a health clinic closes and a mother has to walk 10 kilometers, not 2 kilometers, that has a material impact on outcomes and mortality. Yet against this worrying and challenging backdrop, of course, we're all trying to figure out how to make the best of this and to find the opportunities, even in this very constrained environment. And people are debating how and whether it's possible to do more with less. I think there are three key elements to this debate. The first is the need to focus resources to draw greater effectiveness out of the spending that's available to us and to reduce wastage. A second set of areas that are being examined is how to improve coordination, collaboration, strengthen partnerships. The World Bank compacts are one instance, the US-led MOUs are another instance, and of course in the background there's talk of consolidation to the development architecture. And then the third area is, of course, how can we innovate? New approaches, new tools, digital health, the use of AI, and also how can we innovate in the financing landscape to try and unlock new capital, including from the private sector. So the fundamental question facing us today is that in this challenging landscape, are there positive pathways for affordable and accessible health services for all? And that's what this wonderful panel with me today are going to help to explore. We're going to be talking about effectiveness and innovation, what that means in practice, and some of the things that are being tried. We're going to hear from the World Bank Group, we're going to hear from UNDP, we're going to hear from a number of country partners, Nigeria, Somalia, Ghana, including colleagues online, and a civil society perspective too. So I'm going to start, if I may, with Bruno Rivalan, who's the practice manager for health at the World Bank Group. Bruno, it's 2 years now since the World Bank launched its health mission to support 1.5 billion people to access affordable healthcare by 2030, a hugely ambitious undertaking. Can I ask you to tell us a little bit about how that effort is going, how those compacts are coming together, what we're learning from that experience in this challenging landscape?
Thank you so much, Moazzam, and for Save the Children for organizing this discussion and inviting us to be part of it. And I'm going to start by really why we're here. We are here indeed to deliver a better health outcome, and in 2024, as you've mentioned, our president announced an ambitious health targets to reach 1.5 billion people with quality and affordable health care. And this is not just an aspiration, this is a commitment from the World Bank Group. Why? Because it's key to our development outcome mission, but also it's key for that job and economic opportunity. And health is one of the 5 sectors that is considered as the best driver for that job creation agenda. And in a moment of scarce resources and of competing priorities, that evidence, that narrative, that rationale is really key to keep in those discussions. And those are not easy discussions, as you've mentioned. We're sitting with a really tough reality, but also with that huge opportunity ahead of us. You've mentioned some of the facts and the challenges that we're facing today. I just want to highlight an additional one around the financing. At the current trend, not only ODA for health, and ODA is decreasing, but countries are not stepping up in terms of the financial resources needed to provide an essential package of health services. And at the current trend, it would take 200 years for low and income countries to reach the minimum threshold that is needed. So how can we move forward? We need scale and we need transformation, and that's what we're trying to contribute to. So first, maybe around the target and where we are. We've reached now 575 million people. We have active operation in 60 countries. So that's a strong foundation, but it's not enough. And it's going to be tougher and tougher to get us to the end point. I want to maybe move beyond the numbers to try to look at what is our agenda here. How are we going to reach those people in terms of reforms, in terms of package of services? And for us, it's really a shift. It's a shift that is now focusing on supporting countries in building a digitally enabled primary healthcare platform. And that's really how we see this agenda moving forward. Because you can provide preventive and curative care, because this is what can be closer to the patient, because that's efficient, that's can reduce a lot of the costs. But it's also maybe the place where we can have the greatest transformation, including in terms of digital and AI. So for us, when we look at how to build this primary healthcare platform, it's about first fixing the basics. How do we make sure that facilities are powered, are equipped with water and sanitation, that we have the right foundation for delivering care. The second is how can we move beyond that kind of physical facility model only? How can we look at pharmacies? How can we look at school? How can we look at telehealth and so forth, to really reach the people and get that kind of equity lens into place and really address those geographic barriers. It's also around maybe looking at what are we actually supporting in terms of package of care. The world is changing, demographic, disease burden. How do we look at those new benefit package that really fits today's need across different geographies and population group? And what are here the innovation that has been really efficient in terms of reducing maternal and neonatal mortality, for instance, at bringing NCD into the equation and so forth. So a clear and deliberate focus around scaling up and redefining those benefit package. But then what does it mean from your health workers' point of view? How do we create team-based model? How do we make sure that the upskilling is there and we tap really into that opportunity again with AI and digital health? But that will not be sufficient. We need that affordability. We need to make sure that there is that financial protection at the core of what we do, and that we look at health across the value chain to make sure that the supply chain is there, that the commodities are locally produced, that we are able to be resilient to shock. And I really want to focus on that kind of, let's say, programmatic and technical area, because this is really what will be transformative. And when we went to a number of countries to try to understand that set of reforms, we realized that there was really that call for greater alignment, for greater prioritization, at a moment where you had those huge cuts. And this is where we decided to come forward with the issue of potentially having those national health compacts as one element of the response, not the full solution, but as one contribution. And I just want to make sure, again here, that this is well understood, that those are not World Bank Group health compacts. We don't need a compact to engage in a country. But we realized that countries were calling for this. Were calling for this because they needed to first make sure that health was continued to be prioritized, not only by the ministries of health, but by finance, by planning, at the highest level of government. So that's one key element of the compact. The second is around, again, the prioritization of clear reform, not as a wish list, but with specific targets and clear numbers around how each government will actually commit, whether with increased financing, with better use of resources, with better execution. So a clear commitment on target, a clear commitment in terms of financing, and a clear opportunity also for partners to then come in and align around those priority set of reform. And again, not everything under the sun, but really what are the 5, 6 key areas that needs to be prioritized, now. I want to highlight here that we have 16 countries that have come out with national health compacts. They were launched at the UHT High-Level Forum in Tokyo. And we're getting a number of demands to increase that number. And the hope is to reach 40 by the end of the calendar year. And again, those compacts shouldn't be duplicative. They shouldn't be adding to a number of burden that countries are facing. You've mentioned Ethiopia. I think Ethiopia has to deal with 250 development partners and reporting lines. So the idea is try to defragment that and to support potentially an alignment agenda around those reforms that includes civil society, that includes development partners, that includes ministerial engagement as a whole government. So this is a journey. This is not a blueprint. It's not over. We need to improve. We need to engage better. We need to make sure that countries are actually willing to engage on those compacts, and it's not an additional donor burden that we are providing to countries. And why it's key for us? Because then we can deploy all of the financing, knowledge, and TA that is needed. And that's maybe my last point to answer your question. At the current trend, with our existing operation, we will reach 58% of our target, which means that we need to accelerate. We need to push the envelope. One, making sure that there is country demand for IDA financing, for this agenda. We had this morning, a successful investment round launch of the Global Financing Facility, which is a great tool to help lower the cost of borrowing for health, which can incentivize greater allocation of IDA resources and domestic resources for this agenda. But for this to happen, we need countries to really request and prioritize a health agenda. And we need the whole World Bank Group also to be supportive of that effort. That's on the public side. We can have regional approaches. We can go to scale also with small island states coming into regional projects, for instance. The importance of co-financing and pooling will be critical. And I want to highlight two other innovations in terms of the financing. One, an increased use of debt swap for health that can release fiscal space to really put those reforms into place. And the second is trying to also tap into how can we, let's say, leverage and use better the private sector and how to mobilize private sector capital for this agenda. Not just as a free gift, but really with that access and affordability into play. And that's the reform of the World Bank Group, bringing together IFC, the private sector arm, the public sector arm, and the guarantee arm also all together behind clear and definite policy agenda. So that's kind of our approach to things. The Compact is a key neighbor. It needs to bring the ecosystem. It needs all of us to really move this forward. And again, we will learn as we build, and it's not the final solution, but hopefully a useful contribution.
Thank you, Bruno. Thank you. We will come back to you as the discussion progresses. I'd like to turn next to Natalia Linou, who's the Deputy Director, HIV Health and Development Practice at UNDP. Thank you for joining us, Natalia, here in Washington. I think it's fair to say that UNDP has been somewhat ahead of the curve in driving effectiveness and innovation to try and bridge SDG financing gaps, notably the integrated national financing frameworks that were conceived back in 2015. And I think there's something like 85 countries that are involved with this. But I suspect there are many in the room who don't know much about the IINFFs. Can you tell us a bit about them and how they can play in this landscape that we've just been discussing and the work that you are doing to try and bridge some of the challenges that we face?
Of course, and thank you also to Save the Children for bringing us together. So, the UN likes to use acronyms, INFF. I hope by the end of my 5 to 10 minutes you'll be able to use that acronym too. But no, just in all seriousness, let me break it down. The I, the N, and the FF. So it's integrated national financing frameworks. And it's important because I actually come from the public health space. I'm a social epidemiologist, so I'm not a financing expert. And these plans are not health plans. They're supposed to be integrated in nature across all the SDGs. They address, how do we finance for our social, our environmental, our, all our plans. So it's one framework to advance all the agendas together. And the idea of integration is actually one that, sounds nice, but it's quite difficult. It requires us to think about policy coherence. One part of your government shouldn't be subsidizing fossil fuels if you're really concerned about the air pollution impacts in terms of cardiovascular disease and the cost to your health sector. So really thinking about policy coherence and integration. So these INFFs are not sector specific. They are really a toolkit for a government to move forward a financing plan for their entirety of their development plan. So that's the integration piece. The national piece is equally important. So these are nationally led. They're voluntary. UNDP and a lot of the partners who are at the table provide the technical support. But I didn't call them government-led, and that's an important distinction because these are intended to be a multi-stakeholder process that involves civil society, that involves parliamentarians, that involves the private sector. So it's a nationally led process to decide how we're going to move forward towards this agenda. Government, often it is housed in the Ministry of Finance, and I know our colleague from Nigeria can speak to that experience and other colleagues online. But importantly, it is, it is a multi-stakeholder dialogue and process. And then it's, a financing framework. It's not a budget. It's not a single document. It is a process, and it's about providing a toolkit that thinks a little bit more holistically. So we're not thinking just about public expenditure, but we are also thinking about tax policy, private finance investments. We're thinking about financial sector regulation. And I think importantly in this conversation, how do we think about the health compacts coming into this broader framework? Because if you have one sector that says we will dedicate 50% of our budget to health, as is many of us in the health space talk quite about, the Lusaka and other agreements, but then agriculture says 20% and transportation says 40%, like it all has to come together and add up in a way. But there are synergies. I mean, I think importantly that is what these processes try to address: effectiveness, interaction, so that there are synergies. So let me give you a few examples. Well, firstly, the reason why. So in 2019, we knew that there was a study that about 30% of national development plans were actually costed. So, for those of you in the UN sphere, we just came out of COP, the climate COP, there are all these NDCs. Really the costing and the financing is really important. It's not just setting your ambition or setting the SDGs or your ambition. It's really ensuring that your plan or your ambition is costed and financed using all the tools that you talked about and bringing in the private sector and others. So this approach, interestingly, and I think I want to bring it up in regards to your framing concept, came out of during the COVID period, right? So it was a moment of real disruption. And today we are in a moment of real disruption for those working in global health. And I think it's important to say it was sort of a solution, saying, COVID was hugely costly, it was, disruptive, it was, how do we think collectively, holistically? And I think we are at that moment where the health sector needs to be part of this INFF process. And we are rolling it out, as you mentioned, in 85 countries. And we'll hear from some examples, including Nigeria, where we've done it. But let me give you, and in some places, there is a very specific health target. In Uzbekistan, the INFF really thought through the insurance policy, the national health insurance policy. And in Lao DPR and Bhutan, there have been health sector specific elements. But I want to talk about something outside the health sector, which is in Mongolia. And I'm going to look at my notes because I wasn't involved in this part of it. But in Mongolia, the INFF tried to support, to shift domestic bank lending to green projects from the 2% level at the time to 10%. So it was really an investment in green energy, sustainable economic growth through a green transformation. I work in air pollution and public health, and I know that Mongolia is one of the hotspots where air pollution is costing, the health sector a huge amount of money. So this wasn't, the INFF that focused on the sort of transforming the green kind of the economy wasn't a health sector intervention, but had huge and has huge implications for public health and community health. And so it's important to see that, we don't need to, those of us in the health sector, think only about financing of the health sector, but also of, what social epidemiologists like to talk about, the social, environmental, legal determinants of health. So you finance smartly so that you have co-benefits and not in a way that one policy is actually countering the other policy. So really about cohesion and cooperation. And I do want to say a little bit about the private sector, because this is something that those in the public health community are sometimes weary about, right? It's like, how do we bring in the private sector in a way that is ethical, that is important, and whether that's digital. And I think it's important to also think about the private sector investments in this holistic way of a government being able to say, okay, private sector, come into this part, which has maybe less ethical, to free up fiscal space so that we can still maintain our primary healthcare budget and our essential medicines without that potential, conflict of interest or other things. And then in tertiary care or other places, the private sector might have a bigger role. So I think this holistic framework of the INFFs, integrated national financing frameworks, is really working in many countries. It's not a blueprint, and it's expanding, and I think we need to think about how we engage. And in my last minute, I do want to say that I was really excited to hear what the World Bank is doing in terms of the digital transformation and putting on my, my hat of in the health sector. We're doing similarly, thinking quite a bit about smart health systems. So for example, in Zambia, with the Global Fund, we are solarizing a lot of the health facilities, but also digitizing them and thinking about the financing around it. So we're using carbon credits, and it's really a climate health co-benefit And we see this model of thinking about digital, green, pandemic and climate resilient future for health systems as the way forward. So I'm really glad to hear that there's alignment in approach, and now I think we need to do alignment on the ground too. Thank you so much.
Thank you so much, Natalia. We've heard from a couple of the leading multilaterals in this space, and now we're going to turn to some country-level experiences. And first, I'm delighted to have Rose Keffas here with us. Rose is the Special Assistant on Development Cooperation and Partnerships in the Office of the Special Advisor to the President on the SDGs, the federal government of Nigeria. And Nigeria, of course, has been at the forefront, taken a leading position, and you've embraced the World Bank Health Mission. I think you have a UNDP collaboration around the INFF. You've signed an MOU with the US government, I think, recently in December. And in the face of aid cuts, I also noted a very forward commitment to say that Nigeria would step up to plug the financing gaps and do so at lower cost. So Nigeria is out front, and I'm sure there's lots that we can learn from Nigeria's experience. Perhaps you might share with us some of the work that Nigeria is doing, some of the strategy, the results, and some lessons that others might draw from this.
Thank you so much. Thank you, Save the Children, for the invitation. We've heard from Bruno and my colleague from UNDP. One approach Nigeria took was to launch the Nigeria Health Sectoral Renewal Investment Initiative, which was launched in 2023 by the President in a manner towards a sector-wide approach, reducing fragmentation, partner-driven programming, and also to have a one unified national plan, budget frameworks, and one reporting architecture. So we're proud to say we're one of the countries that have launched the compact with the World Bank. And this was done under the presidency, in partnership with the subnational government, development partners, with a shared commitment to have a unified, efficient, and resilient health system. So we're very proud to be one of the people who have launched the compact. So 3 strategic principles we've done was domestic ownership, like they all mentioned, in a way that is being spearheaded by the Minister of Health and also Minister of Finance, in a way that to expand quality basic healthcare to citizens, affordable, like Bruno mentioned, and also enabled by technology, have a skilled workforce, gets towards improving concrete outcomes. Another thing was diversify our financial architecture, which UNDP has been of great support. Pre-COVID, we did a costing exercise, and it showed that we needed $100 billion to achieve the SDGs by 2030. That's pre-COVID, so it's been exacerbated after COVID. And so one of the things we did in partnership with UNDP was to launch the Integrated National Financing Framework. And Nigeria was one of the first in the Global South to launch this framework, and I think Finland in the Global North. And basically, my colleague has explained what the INFF is. It's just a financing strategy. How do we align our financing strategy with our development priorities? And how do we begin to mobilize domestic resource mobilization using private and public capital? Because there's strong ODA cut. So we had this framework launched by the Minister of Finance. So one thing countries can learn from Nigeria's INFF is the governance structure is fully led by the Honorable Minister of Finance, with development partners being the co-chairs and steering committee, World Bank, IMF, AFDB, regional multilateral development banks. So we've launched it, and also it's just a way of how do we look beyond ODA, how do we begin to mobilize domestic capital, because our national development plan has shown 86% of our private capital will come from, 86% of capital will come from private capital, so meaning less on public financing. Public financing is not enough, so that's what this INFF framework has shown us. So that's one of the success stories we can share from Nigeria, and lessons people can learn is credible national plan before entering partnerships. We've demonstrated strong partnership with the World Bank, using more of a sectoral-wide approach to prevent parallel delivery and have more of a holistic and integrated approach. And placing the finance ministry at the center of health agenda. I think Bruno mentioned it. It's not just a health sector conversation. Health has been seen as a fiscal and a macroeconomic issue. So for us is we've signed this MOU with the U.S. government in December 2025 as a way of, one of the ways strategic move towards sustainable trade and investment-based partnership. The government is committed to allocating at least 6% of its annual federal and state budgets towards healthcare, and also the total packages of 5.1 billion over 5 years represents the largest co-investment. I think Bruno mentioned that we need to begin to look at co-financing, and that's one of this administration has done. Aid is not enough, and also how do we, so we designed our health architecture by launching the Basic Health Care Provision Fund, is the core at Equity in 2024. And so basically the swap architecture is designed to ensure that external financing flows through the fund is around and enough for everything. The 570 million primary healthcare projects targets 40 million vulnerable people, particularly women and children. So I think our government is doing a lot in partnership because ODA's court has been cut, and how do we begin to mobilize domestic resource mobilization, and healthcare is at the top of the agenda of this administration. Yeah.
Great, thank you very much, Rose. If you were to pick a top lesson from Nigeria's experience as you have navigated this landscape, what would it be?
I think political will. And also, like she explained, the INFF has been a strong tool for us, where we've seen we need to begin to align our financing strategy with our development agenda. And at the top of the INFF, with the costing exercise, even our budget is not enough to address our development, our financing, to finance our development. So how do we begin to look inwardly to mobilize domestic resource mobilization? How do we partner with the World Bank to achieve the universal health coverage? Yeah.
Thank you very much.
Yeah.
We're going to turn next to Dr. Hassan, who's the Director of Planning at the Federal Ministry of Health in Somalia. So a country that I visited just last year, some months back, facing a whole range of challenges. And indeed, when I was there, some of the work that we've been doing that was funded by development partners is under pressure. Indeed, there are clinics closing. There are real challenges with malnutrition in the wake of drought. So lots of real challenges in a fragile state context like Somalia. And as Director of Planning, Dr. Hassan, you are very much at the forefront of navigating these challenges. Can you tell us a little bit about how the government of Somalia is approaching this and this agenda of more with less, trying to sweat the resources that we have further? How do you approach this in a context like Somalia? And tell us some about the challenges and the innovations that you're trying.
Okay, thank you very much. Moazzam, and also I would like to thank Save the Children for organizing this meeting, and I just greeting everybody who's actually in the meeting, whether connected online or in the meeting room. Actually, I'm so glad to be part of this discussion, even virtually. Absolutely, you're right in what you have observed. And when funding cuts happen in Somalia, the effect was very immediate. And now we're not talking about small adjustments. We are talking about facilities actually reducing services. We're talking about a supply of medicine was hugely actually interrupted. Healthy workers actually going unpaid for, months. And, in some cases, clinics at risk of closing actually altogether. To give you a, a background of Somalia, the country has been a fertile and for many years actually, and we, as a government, we have, as a Somalia, we have more than 1,400 health facilities that were mainly functioning prior the funding cuts actually. We believe this reduction continues if this continues, the remaining facility that will function, it will be about 618 facilities. Only 618 facilities will be able to function until the end of this year. Due to the conclusion of some projects, or mainly all the projects in Somalia, including a funded project is from the World Bank, Damal Afimat, which actually is scheduled to end by December 2026. So you can see the scale of the issues. Also, the other funding actually, that has been reduced or about to reduce, actually closing some other projects, such as Better Lives, that UK actually used to fund, which ended March 2026. And the reason is Somalia actually used to and still, heavily reliant on external financing. So when partners like the US reduce support, and when we anticipate cuts from other donors, whether European countries or the UK, that actually created real uncertainty across the entire system. So what we're saying is actually, the main message is actually quite simple, and we see that a sudden cut is a disaster to Somalia. So what we're saying, we need to see a predictability as much as we need funding actual levels. So it's not just about how much funding comes in, but whether we can help, we can plan around it. So what we see is sudden cuts make it very difficult to maintain continuity of care or allocate resources efficiently. So we asking partners to think in a multiple commitment. We do not want to lose the hard gains, and we look how many millions have been invested in Somalia. So would we see that the sudden cut and has actually created disasters in Somalia, as you have seen in your eyes. So what we're saying is we need to have, as some other panelists mentioned, we need to have a coordinate funding, and instead of fragmented and short-term projects, we started looking into, the government actually started to looking for into a pooling funding mechanisms where multiple donors can create a basket for health financing. So this is what we're doing at the moment. When it comes to the idea of doing more with less, of course, we believe that we are focusing on efficiency. We realize that we really think how we utilize the available resources. We are working hard to reduce what's called duplications, We need to improve how we track spending and prioritize the impact interventions. But what I want to say honestly, there are limits. And in Somalia, where domestic resources are very constrained and where needs are still very high, there comes a point where doing more or less simply becomes doing less with less. And that is actually a disaster. So yes, there is a real concern that if global funding continues to shrink, fragile countries, not only Somalia, but others also, for the context, like Somalia could be left behind.
Thank you. Thank you, Dr. Hassan. It's your opening statistic of 1,400 health facilities going down to 618 is salutary, sobering, and frankly shocking. Bruno, when we get to Q&A, I'm going to ask you, what would you advise Dr. Hassan to be thinking about? What would you advise the government to be thinking about, given the very sharp end of the challenge that they face? But we're going to turn next to Dr. Sodzi, who is the CEO of the National Vaccine Institute in Ghana. Welcome, Dr. Sodzi. Sorry you can't be with us here in person today. Ghana is looking towards self-sufficiency, given the pressures on development cooperation. I know that you are placing a significant emphasis on partnership with the private sector, trying to mobilize private investment. And the National Vaccine Institute is very much at the forefront of that effort. Can you tell us a little bit about the approach that the government of Ghana is taking in this landscape, and share some of your experiences with us?
Well, thank you very much. Lots of gratitude for the opportunity to be part of this wonderful panel and the discussion. I think that many of us are aware that there have been changes in the global financing landscape, and those call for a lot of new priorities by governments. And in Ghana, the president has rolled out a number of bold initiatives, both in the area of vaccine self-sufficiency, free primary health care, management of complications from non-communicable diseases, freeing up some resources, additional resources for the health sector. So it calls for clarity on what the priorities are by government. It also calls for greater fiscal discipline. You know that Ghana has for the past 2 to 3 years been under a World Bank IMF program. So that context is important if you pay attention to all of the changes that have happened and continue to happen, that there's been a tight fiscal space. So it has called for greater discipline to be able to focus on key priority areas. And then mutually beneficial partnerships. And you referenced the private sector. I'll say a little bit about that in a bit. But it is important that we embrace the private sector in terms of the innovation that they bring. And then in a win-win situation, especially in an area of health security, like in vaccine manufacturing. So this is just by way of context. But with Ghana, yes, the president is very clear that we want to move towards vaccine self-sufficiency. And Ghana came up with an interesting model of partnership with the private sector. So we set up the National Vaccine Institute that is supposed to be an enabler of the ecosystem. So mobilizing, financing, facilitating tech transfers, ensuring that there are partnerships with non-profits, for-profits, even the banks and various universities, spurring research and development. But when it comes to manufacturing itself, this is where we are partnering with the private sector, and there are 2 companies, Atlantic Life Sciences and then DEK Vaccines Limited, and they are working in close partnership with the National Vaccine Institute. So when we talk about resource mobilization, it is on behalf of these 2, and that partnership is working very, very well. And so we have an ecosystem where we are doing the manufacturing, but there's also the collaboration with the EPI program that is supposed to be doing the actual distribution of vaccines and then immunizing the population. Together, we're working with the likes of the World Bank, talking to Afrexim Bank, talking to AFDB, and a host of others to see how we can mobilize the resource. As you recognize, it tends to be very resource intensive, and it's a little bit of a challenge for the private sector to be able to raise the funding that is required to be able to do what is needed. What government then does is to create the conditions that set private sector up for success. So in some instances, it's about provision of sovereign guarantees. It's about government saying that these are companies that we back, that we absolutely support, and therefore it is okay that you support them. In that case, the private sector is not, in a strict sense, private for profit, but they are really serving a social good, if you will. And in the case of vaccines, they are helping to address a matter of health security. And in the case of vaccines, it's even more critical because there isn't such an actual true market. These are products that are bought by governments. And so without government support, you really are not going anywhere. So that is very critical. And that is the kind of symbiotic relationship that we are trying to nurture. So the conversation then shifts to how can you provide advanced purchase commitments to these private sector entities, because that becomes a de-risking element that financiers will look at, take inspiration from that, and be able to provide them with the funding that they need. In Ghana, there's an interesting conversation now about the fact that by 2030, we are graduating from Gavi. And this means that the budget is going to balloon from about the 25 million that we paid, let's say last year for the co-financing mechanism, to something to $50 to $60 million every year. So the National Vaccine Institute is coming to grips with that and wondering, can we set up a vaccine fund? And can this vaccine fund attract funds from a variety of sources? So from government allocations, will the government be willing to consider a small tax element? Can we bring in private sector so that they would bring in the ability to invest and grow it far in excess of what we would need? And can we look for some donor support as well? So a variety of funding measures. And of course, if you box this against the fact that the companies have advanced purchase commitments and government is guaranteeing to purchase, then it becomes more attractive to those in the private sector. So it's just a little bit of thinking outside the box to be able to manage what we see to be something that is coming through. Maybe I would end by reflecting a little bit on how we can sort of support and have a better understanding of the needs of the private sector, especially as it relates to seeking financing. Because I think when it comes to issues of health security, the private sector's intervention in the health sector, sometimes, financiers don't seem to have a good grasp of what it is that they need, in terms of the long-term financing, in terms of the periods of moratorium, in terms of the low interest rates and other such interventions. So it becomes a little bit challenging. So I think it's important that people understand what the issues are here. And then when they come in to partner, they partner well so that it will really serve the national agenda in the way that it is envisaged. Of course, it is not just the private sector. It means the government must also play its part. And in Ghana, the government, in addition to advanced purchase commitments, the discussion around the vaccine fund, there's also the $50 million that His Excellency the President has advanced or allocated to the National Vaccine Institute to serve manufacturing ends, research and development, compliance with international regulatory standards and the like. The President has recently uncapped the NHIS. There used to be a ceiling, but His Excellency the President has uncapped it, freeing over $300 million extra every year that is accruing to the health sector. So it is some of this that is going into free primary health care, into the Ghana Medical Trust Fund, which is supposed to be helping to manage the complications of non-communicable diseases. And again, the context is that we are under an IMF program, so things are tight, and yet all of these things are being rolled out. So yeah, lots of innovation, a lot of thinking outside the box, a lot of collaboration between public and private sectors. Over.
Dr. Sodhi, thank you very much for sharing those experiences with us. And turn to the last of our panelists, Rosemary, last but not least, Rosemary Mburu, who's the Executive Director of the Waki Health, she's the Waki Health Regional CSO representative. Civil society organisations, of course, including Save the Children, are desperately worried about the current state of international cooperation and future directions. And indeed, a number of civil society organizations have been critical of some of the responses that have come into play. I'd love to hear your perspectives of what's playing out on the ground and any insights that you would like to offer both to the multilaterals and indeed to the country governments. And then we'll turn to the audience.
Yeah.
Please.
Thank you so much. It's been great listening to the conversation. There's a lot I'm taking in from the countryside, from the agencies here. Just a quick reflection in saying that one of the most important things for us to remember, even as we have this conversation, is that the ultimate objective that we want to achieve is equitable access to essential health services. And we also want to remember that at this moment, we have over half of the world's population not accessing essential health services, according to the Global Monitoring Report on UHC. And we also know that a majority of people who are not accessing health services, either in sub-Saharan Africa or South Asia, in particular when it comes to maternal and child health, where we are seeing nearly 90% of deaths, maternal deaths, occurring in sub-Saharan Africa and South Asia. And so ultimately what we want to safeguard is equity. And so some of the concerns that impacted communities and civil society have been raising include the fact that, yes, on one hand, we see the need for effectiveness, we see the need for efficiencies to open up to private sector, to open up to technology. And I think that's good because then it gets us to be more effective, work smarter, value for money, and all that. But when we talk about more with less, then obviously there's going to be some trade-offs. And I think what we haven't done very well is to interrogate what those trade-offs are, particularly think about the impact on people, especially the people farthest behind, the people who are most likely to be missed by health systems. So when we think about how that looks like and what those trade-offs are, ultimately we don't want equity to be one of the things we give up. We don't want equity to be the collateral when it comes to more for less. Less, we are saying what? More with less. And I like what our colleague from Somalia is saying. It's less with less, in some situations. And so we have to think about how do we ensure that it's not a zero-sum game and that there are benefits around that. So in thinking about health reforms and thinking about health initiatives that introduce and primarily are focused on efficiencies, effectiveness, coordination, alignment, we ought to understand that those kind of initiatives have a blind spot to some of the social, political, and legal barriers that actually limit access to care. And so it's important to think about, when it comes to trade-off, how do we ensure that we are trying to find a balance, and we are also very much guided with context-specific data to decide what do we prioritize for which context. But it is also important to say, how is prioritization done and how is agenda setting done? Who decides what gets funded? Who decides what doesn't get funded? If you think about maternal and child health, and you think about the Every Woman, Every Newborn initiative, one of the striking data points that came out of the International Maternal and Child Health Conference in Nairobi a couple of weeks ago was that, Awale has three priorities. One is to make sure that women are seeking care. They're going for screening. And the second one is that as women go for care, they are being attended by skilled birth attendants. And the third one is that they are accessing the commodities that are needed for safe maternal and child health. And it is this third one of accessing commodities for safe maternal and child health that is lagging very much behind. And we all know that there is a continuum of care when you talk about the care package, the continuum of care. And so my point is that in many countries, because of the fiscal space, you find that the continuum of care or the essential care package does not include all the services that could be offered. And so the question is, how do we decide as countries, as partners, as a collective, what gets funded and what gets left out? And one of the things we are learning, and also the concerns we are raising, is that it's important in those decisions, those governance decisions, that those decisions and the governance is inclusive, so that you have impacted communities, you have civil society as part of those decisions as countries grapple with that. And we are not blind to the fact that countries are navigating a convergence of shocks, a convergence of challenges. And I think that's why partnerships like this is why investments like the GFF, investments like IDA, and all the partnerships are important in order to journey with countries to unlock and navigate these challenges.
Rosemary, thank you very much. A really very powerful set of points. Thank you very much indeed. Okay, we're going to turn to the audience, but I'm going to come to Bruno first. So if you could show hands, anybody who'd like to come in? Okay, I have a gentleman there, a lady there, and a third here. We'll do a couple of rounds in threes. Please come to the mic, but whilst you make your way to the mic, Bruno, I'm going to turn to you and put you on the spot. Somalia is a particularly challenging context at the sharp end of the business in all respects. What would you say to Dr. Hassan as he navigates that set of challenges that he faces?
So maybe start by something actually positive to build on, as Somalia has delivered results. So even in highly fragile setting, there's a way forward. And I think through our partnership, Dr. Hassan, we've been able to provide services to 4 million Somalis, right, with your leadership and guidance. So I would say three things. One is strong leadership. For instance, Somalia has access to IDA financing, mostly on grant terms. There's GFF, but we need to make sure that there is this demand for a health allocation. That's first. Second, co-financing and pooling, we've discussed. And here we want to make that simpler for countries, and we want to make that simpler for donors. We have been working with Gavi and the Global Fund around trying to expand the number of joint operations and create two-stop shops, let's say, to avoid having to negotiate every time new agreements and facilitate that co-financing. The Global Financing Facility has created also a framework for bilateral contribution to be aligned under one mechanism. And again, that is a moment where everyone is looking at how to be more efficient. Those are concrete ways that can help Somalia. And then we need to be intentional around the collaboration, designing together up front, beyond designing, delivering together also, and trying to look at how can we move just beyond financing of services to that broader enabling environment. Even in fragile state countries. And again, I think we had good example with the National Health Compact in Syria that shows what's possible in terms of FCV countries and in terms of reforms. So just
very good. Thank you very much indeed. Please, we'll hear from three speakers from the audience. Please limit yourselves to a question, a couple of minutes maximum, and please start by introducing yourself.
Right.
And if you're directing a question or a comment at one of the panelists, please feel free to name that person.
Great. Thank you very much. John Avasco with World Vision International. First of all, thank you to Save the Children for organizing this very interesting and important panel. I want to build off of what Bruno said in his opening remarks about moving beyond the physical facilities, thinking about how that type of mindset can help cope with the less challenge that Dr. Hassan identified. And, we know that I understand Somalia has launched a community health strategy. And I'm curious, to what extent do we think community health workers and improving how community health workers are deployed and trained and aligned can perhaps play a part in that coping strategy? Thank you.
Thank you very much, John. Please, the young lady in the green.
Hi. Thank you so much to the panel and to the organizers of this event.
We can stop thanking Save the Children, by the way. It's not. I believe me, it's really not necessary. We're very grateful to be able to bring colleagues together for a conversation.
To be frank, I wasn't going to, but then the person in front of me did, and I felt awkward. So assumed thanks. So this is really a question on the converse of more with less. Oh, also I'm Erin McConnell from Treatment Action Group, TAG. One of the comments on the panel suggested that countries haven't really stepped up in health financing, but that statement seems to gloss over an aspect of the immense debt burden that we're seeing in countries both before the crisis, well, the war of aggression in Iran, but that's neither here nor there, and now after this energy crisis, as well as, there's more money going to interest on debt payments than in health and education, and this is alongside tax rates being historically low in some jurisdictions, including here in America, and countries losing an estimated $492 billion annually in tax revenues due to tax abuse and tax havens. There are many solutions that the panel offered on how to expand financing for health, but the panel hasn't really addressed a core issue, which is what are some solutions to meaningfully expand that pool of money and to actually do more with more, to expand revenue to cover social goods, including on health, without over-relying on a sector that benefits immensely from the system as is and from the root cause of so many of these low revenues. Thank you.
Thank you so much, Erin.
Hello, I'm not gonna thank anyone. My name is Raja Menk from Moazzam, Canada. So I really liked your point about not duplicating efforts and equity and reaching the people that are further behind. I would like to know from your experience, especially in fragile contexts, how has been the coordination with local humanitarian actors, especially with shrinking funding across peace, development, and just Nexus projects in general. I'd be interested to see if there has been a little bit of synergy with humanitarian actors who are delivering WASH or sanitation projects, and how that has impacted delivery specifically for refugee populations in some of the fragile contexts that you're working with, and especially Somalia as well. Thank you.
Very good. We don't all, I don't think I'll go across all the panel to respond to the questions, but I'll invite you to kind of stick your hand up and come in to respond to any of the points that were raised. I'd like to come in first. Natalia, go ahead, please.
Just some thoughts in terms of your question from TAG. I mean, we didn't yet explicitly talk about health taxes, and for those of us who work on non-communicable diseases, obviously taxes on tobacco, alcohol, sugary sweetened beverages are really an effective tool that is underused. There's an estimate that if you raise the excise taxes on tobacco, on those three by 50%, within 5 years you could generate $3.7 trillion globally. So that's a huge tool, and it's a win-win because also that would mean less consumption, less cost to the health sector. So that's one underutilized tool. Another area that we didn't quite talk about is in the doing more with less is the law. And I think you mentioned it, Rosemary. Policy interventions can be zero cost, and in UNDP spearheaded something called the HIV and the law sort of process, maybe in the last 20 years, looking at things like decriminalization. There are policies that can save you a ton of money, and we're seeing a retreat on sexual reproductive health and rights, and that will cost maternal lives. And so really saying that this law that you've put forward has a price tag to it, I think will be important, and it costs you, other than political capital, it doesn't cost you real money. So I think those two areas we need to be a little bit more explicit around. Thanks.
Thank you. Rose?
So for me, I'll talk about diplomacy and partnerships. Currently, our minister is chairing the G24 bringing together ministers of finance and CBN governors from emerging markets to focus on optimizing resource mobilization and also the alignment between finance and health. So Nigeria has begun, unifying between health and finance and making it, a macro on fiscal issues. And also Nigeria has captured the World Bank pivot on, the Universal Healthcare Knowledge Hub. And it's a way for technical assistance, training, effectiveness, which is, doing more with less. And also in terms of ensuring equity and access, we have the Basic Healthcare Provision Fund, with IDA financing that has made finance accessible to the subnational government, worth 260 billion naira. Also, we've invested $570 million for primary healthcare revival at the subnational level to ensure that no one is left behind. And also on manufacturing and self-reliance, like Ghana, our neighbor, our compact commits to boosting local production, which will aid job creation.
Would anyone on the panel like to engage with the questions around community level action that John asked about, or indeed the need to integrate and the focus on refugees? Anybody like to come in on that? Go for it, Natalia.
Just very quickly, super supportive of the community health worker model as an effective and low-cost model. I think also we do need to think of the conditions. A lot of community health workers themselves are women, underpaid, so we need to think of that sector as an important one to invest in. Many are informally employed, but UNDP is thinking a lot about that in our jobs work, and I'm sure the World Bank is.
Yeah, and actually that's what I was going to say, that it's a very critical element, and we need to think more strategically about how we can strengthen community systems as part of health systems, as opposed to it being like a sideline or like an add-on, but be part of the mainstream. Most community health workers are not integrated in the national or subnational payroll, and that means they are voluntary, and that keeps them more vulnerable. Most of them are women, and they are the first to feel the impact of any crisis and the last ones to recover.
Thank you for that to both of you. And I know from Save the Children's work, and I'm sure is the case with World Vision too, just how important a role community health workers play in trying to improve primary health outcomes. Let's take a second round. Hands, please. I can see someone's already strategically moved towards the mic. We have a young lady at the back. I'll take a third, a gentleman here, please. Thank you. Please introduce yourself. And
all protocols observed. Sean Baker with Helen Keller International. Natalia, you actually started answering my question. And looking at fiscal policies, I was referencing particularly the World Bank Investment Framework for Nutrition, among other things, recommends that looking at fiscal policies which promote healthy diets, including sugar-sweetened beverage taxes, but also the broader range of ultra-processed foods, which both dramatically reduce the morbidity burden on the health system and generate revenue. And so my question was going to be, what's the appetite, every pun intended, to start taking up those policies? But maybe the finer question is, how can we use this crisis to get across some of these huge policy wins, which will do both, right, which are double wins? Not to minimize, the straits everyone is in, but it may be more politically palatable during crisis like this to push through policies that will both improve health outcomes and generate revenue at the same time. Thank you.
Yeah, great question, Sean. Thank you. Please.
Hello, my name is Maya, and I'm representing DMUN Foundation. I wanted to direct this question to Natalia. From what I've gathered, you suggested using the INF to direct private investment into certain areas to free fiscal space for primary care and essential medicines, and emphasize a holistic government-led framework for engaging the private sector. But you also acknowledge discomfort about private sector involvement in the public health field. What safeguards or governance mechanisms have worked best to manage conflicts of interest, accountability structures, independent oversight, and transparency, etc.?
Thank you. And thirdly, please.
Hi, my name is Do Zhang, and I work in the Global Environment Facility, the GEF, here housing the World Bank Group. My question builds on the conversation about policy coherence. And we know that conceptually, policy coherence has been discussed a lot and in our environment world as well. I just wonder, from a practical perspective, what are the biggest barriers you come across for collaboration, for working across sectors in the system, and also how have countries actually managed to overcome these barriers in practice? Thanks.
Thank you. Natalia, I'll come to you first, but just to
Let's get a question here.
We'll take them in rounds of. Should we do another round of 3? Yeah, just give us a second, and we'll do a final round. Okay. Natalia, we'll come to you first, but I'm going to just forewarn Dr. Sodzi that I'm going to turn to you for a comment on this, on Sean's question around fiscal policies. You talked about the pressures in Nigeria around the fiscal space, and whether there's a debate around health-related taxes going on in Ghana. Please, Natalia first.
Yeah, and I'll try and be quick. To the first question, on sort of is there an appetite for these taxes and whether it is in times of crisis that you can push them through, I think that you might be right. I mean, there are the debates of whether some of these taxes would be regressive and, all of that kind of narrative that obviously the industry is invested in pushing forward, or other narratives around transboundary sort of smuggling, but there's enough evidence to show us that this can work if it's done right. So I think there is an opportunity, and going a little bit further, since you talked about nutrition, and I work in the climate and health space, I think also the Eat Lancet Commission, and there's movement also to think about how we think about other kind of food sources that are low cost, good for health, etc. But again, a much broader conversation. Maya, I loved your question, and I think within UNDP, you would get different answers. And my colleague Tim, who kind of leads this INFF work, is online. I'm in the health space. And so I work closely with WHO, where there are very clear guidelines. We don't work with the tobacco industry. We don't work with arms. So for, I think, the public health community, there's been a very principled, there are real risks. But your question now is really more, and I'm curious what Bruno thinks, in the digital space, the digital health space. We need to turn to that. It's, will save lives, will get us access, but then there's the questions around data, privacy, and ethics, and, and so I do think there are groups that are thinking about guidelines. The problem is some of the technology is moving faster. So I would say that safeguards, the blanket safeguards of just don't engage with tobacco is not going to work in places where you have to engage with the private sector on, say, digital transformation. So they're more and more important at this moment. And I don't know, Bruno, if you want to add to what you guys are thinking about that. Go ahead. Putting you on the spot.
No, and I mean, I think there's a broader point that is cutting across around the importance around these policies and regulation. Across those different solutions, across those different innovation. And this is really something that we're trying to look at in terms of what has worked, what is missing, and what are the tools that we can put forward to improve those policies and regulation. So Rose, you mentioned the Knowledge Hub, the UHC Knowledge Hub in Tokyo. I think that's one example of that kind of knowledge creation, curation across health and finance that can help in that policy coherence, that can help in sharing experience across countries of what has worked, what has failed, and how to improve it. And in terms of the digital and AI, us also are at the bank, we're starting, we're trying, we're learning, and we just had to accelerate this effort through one of our projects in the Pacific Island that is all about digital and AI technology for health services in remote areas. It's also looking at our safeguards policy and again, not having all of the solution, but learning from other countries.
Interesting. This is a big challenge right across the board, I think, not just in health, but for all of us in our societies just now. Dr. Sodzi, is there a debate in Ghana around health-related taxation to address some of the resource pressures that you face?
There is no active debate at the moment. I mean, I know that the health insurance levy that is being implemented now is a very progressive taxation system. And then also within the COVID pandemic, we had a COVID levy So at least for some of us, the thinking was, could we just convert that into a bit of the vaccine fund that some of us are advocating for? But you have to understand also that there's always the political influence where the president had made a commitment to scrap the COVID levy, and so it has been scrapped. So I think it would take quite some advocacy to get anybody in Ghana now to be supportive of a new taxing regime. I know that within the party's manifesto, there are provisions for sin taxes. We have a high rate of road traffic accidents, so perhaps to get some of the insurance commissions to pay a percentage to the health insurance levy. But till those happen, it becomes a little bit challenging as to how one can clearly see a new form of tax being introduced. There is no active debate at the moment, but we have made a proposal as the National Vaccine Institute that it is something worth putting down on the table, especially when we look ahead and see what is coming.
Thank you. Maybe it's something for us to go away and think about. How does one campaign around sin taxes across a whole range of countries? He might say, looking at my colleagues in the front row there. Okay, we've got 5 minutes left. We'll take, in fact, not 3, but just 2, if I may, please. This gentleman here, and we have someone else who's raced to the back. All right.
So I'm not saying thank you, so
okay.
I'm going to
please be brief, and we'll try and close.
My question is to Dr. Tete from Ghana, because he mentioned about the Gavi, that's the Vaccine Alliance, coming to an end in year 2030. That's the end of the SDG, and he already said that there are plans and protocols in place for them to start manufacturing vaccine locally. But my question is this: there are all other countries amidst the cuts from the USAID AIDS and also WHO also warning also both Middle East and Africa that the vaccine production by Gavi is going to come to an end by 2030. So what advice does Dr. Tete have for all of the sub-Saharan African countries who are caught amidst this AIDS cut from USAID and the like, that they are not actually prepared for what is coming? 21 million babies are being given birth to annually in sub-Saharan Africa, and that's going to be a risk for all these babies. So what?
Thank you. We've got the question. What's your name? You didn't introduce yourself.
Oh, sorry, my name is Dr. Ojo. Thank you.
From?
And I'm here from Maryland, United States.
Okay, very good. Thank you. And then one last question, please. Thank you.
Good afternoon. My name is Jean-François Zardif. I'm an advisor with Results Canada. And I'm interested in seeing the health taxes, etc. But I'm wondering whether we're actually addressing the right problem. There is $100 billion worth of IDA that's available to fund health projects. The problem is there is no demand from countries for those. If you look at what happened the first 2 quarters already of IDA 21, not a lot of demand. If you look at what happened in IDA 20, we did the 3 health indicators were not reached in IDA 20 because there was not enough demand. So I think one of the questions is, how do we make sure there is demand and we really create the basis required to get to 1.5 billion by 2030.
Thank you very much. Okay, we'll go quickly to Dr. Sodzi and then Bruno on the IDA, and then I'll say a couple of things to close this out. Dr. Sodzi first.
The question requires a lot more time, but to be brief, it's very critical. The African Union, working through Africa CDC, has set these targets of 60% of vaccines to be manufactured on the continent by 2040. And so that is the driving target. I think the direct answer to your question will be that the 10 manufacturers that have facilities that are ready to manufacture would need to be coordinated. Sometimes one gets the impression that everybody wants to manufacture everything, and that's not feasible. Because if you look at the 10 together, they have enough capacity to meet the needs of the continent. So Africa CDC would need to coordinate that effort so that we complement each other as opposed to being competitive. Similarly, there is the initiative around advanced pool procurement. Again, if we are coordinated, then you know that there's a market for whatever it is that you're going to manufacture. And I think this will help us to mitigate some of those difficulties that you talk about. Thank you.
Thank you. Bruno.
So just to add on that, the importance of that regional integration agenda is key in terms of also regulatory capacities to make sure that this is easier for private sector to invest. And we've just launched yesterday a new initiative to support the AU's goal of local manufacturing. With our own hope is to help Africa to double the number of health products that are produced in the continent. Just wanted to share that as also a key element of our agenda. On IDA, I cannot say more than what you mentioned, Jean-François, but just maybe to add that not only there is this 100 billion IDA envelope available that can be used for health, but we have also secured more than 1.4 billion of grant financing that can be tied to IDA, which again can be an incentive, but for that we need an IDA for health. And so we need that demand and we need that push from countries to make sure that they want to invest in this agenda.
Thank you very much to our wonderful panelists, and thank you to all of you for participating in this conversation. I'm not going to try and sum up the conversation, but I might just pull out perhaps 4 or 5 points that I think I take away from this conversation. The first is the reminder of the need for national level ownership and political will. We're in unprecedentedly difficult times, and to try and navigate this, leadership is absolutely critical. So we all need to be reinforcing that national level leadership. Secondly, the need for quality partnerships. Part of the reason we're in a mess is not just because the resources have been kind of falling off a cliff in some instances, but also because the quality of partnerships is not adequate. We need more credible, predictable financing, and actually we need to pool financing. In the health architecture, Gavi does a fantastic job. We're an implementing partner with them in Sudan. We're delivering vaccines at scale. But you know, when you show up under a tree, the mother who comes with the child doesn't just want a jab in her child's arm. She wants to deal with the whole range of ailments. And it's not right that those on the ground are left trying to mix the cocktail of funding right. We need to address the architecture issues so that we can deliver credible and really respectful, I think, partnerships. Thirdly, important reminders around innovation. Fourthly, the need for public financing. And I think an interesting takeaway around sin taxes and you know, electorates don't want to sign up for taxes, but if ever there was a time to engage with those health-related taxes, it's got to be now. And then just lastly, a reminder that actually there are limits to more with less, particularly in difficult contexts, in fragile states contexts. In fact, we're looking at less with less, and frankly, that isn't good enough. As Rosemary reminded us, our objective is equitable access to essential health services. And perhaps something that we could all take away is, in all the work that we're doing, to ask ourselves the question, what does this mean for the poorest 25% of our people? Right? And if we don't have a good answer to that, then frankly, we ought to be looking for better solutions. So yes, less with less isn't really good enough. And that's a huge challenge for us all to make the case and to try and turn around the bleak circumstances that we're in. But thank you to our panelists. Thank you for the work that you are doing. Thank you to those in the audience who are committed to this agenda. And yeah, onwards.
Can we thank Save the Children?
Sorry?
Can we thank Save the Children?
No, don't bother. Thank you very much. Thank you for coming, Rosemary.
No worries.
That was really great.
Fine. I brought my party at Harvard, so I brought my classmates to join.
Oh,
yeah. So when Natalia is school, so she's she's from Moazzam now, so she was
So you guys